So we have got a 68-year-old woman that's been referred to outpatient after a fracture of the distal radius. He's got 4-month history of lower back pain that's worse when the lifting object. Past medical history, got a 20-year history of adrenal insufficiency. He's got vitiligo that's been controlled by hydrocortisone, and has got esophagitis as well. So we've got vertebral tenderness of the spine, and also DEXA shows a T-score of -2.6. So what do you do for this patient? With who has got a DEXA scan, a T-score of -2.6, very important, and also has got a lot of comorbidities, including adrenal insufficiency and vitiligo that's being used with hydrocortisone, and also esophagitis as well. What do you do for this woman who's suffered a fracture? Give you 5 seconds. Pause the video if you need more time. Pause it if you need more time. Have a think. Okay? Now, the correct answer in this case, obviously a patient with a history of fracture, persistent lower back pain, and also a DEXA scan that's -2.6, a T-score. That's a diagnosis of osteoporosis. So if you think this is osteoporosis, well done, you got the answer correct. Now, the question is, where do we go in terms of further management? Where do we go next? Because that's all going to be based on the clinical vignette in terms of the contraindication. So the vast majority of students here will jump into alendronic acid, alendronate in option A. That is incorrect, because alendronic acid, alendronate, is an oral bisphosphonate. It's a first-line treatment for osteoporosis, normally, right? Because of its ability to inhibit osteoclastic activity and bone resorption. However, in this particular patient, alendronic acid is contraindicated because we've got a history of esophagitis already. And we know that bisphosphonate can exacerbate existing esophageal disorders and must be avoided in this case. So even though you've got the diagnosis of osteoporosis, the management is not going to be the first line management using alendronic acid for this particular individual because of the comorbidities. Bear that in mind. Some students actually like to choose calcium and vitamin D supplementation, and I would agree with you in normal circumstances, because even though calcium and vitamin D supplementation is essential for all patients with osteoporosis to reduce the fracture risk, is not considered a definitive treatment, okay? Because these supplements should always be used in conjunction with other interventions, much more definitive interventions for the optimal management of osteoporosis, okay? If you did choose C, denosumab, well done. Okay, well done. Let me expand that a little bit more. Denosumab is a monoclonal antibody that inhibits the rank RNK ligand and is the most appropriate choice for this patient. Okay, why is it? Well, it's really a second-line treatment for osteoporosis if bisphosphonates are contraindicated or aren't tolerated. And denosumab really reduces the fracture rate and is safe for patients with esophagitis. So that's the best option for this case. Now, you might ask me, Phil, why don't you just give out PPIs, proton pump inhibitors like omeprazole for patients with this esophagitis and taking an alendronic acid? Well, that's a good question. What I would say is the fact that the PPIs are not going to be useful due to the local effects of alendronic acid, alendronate, on the esophagus, whereas the PPIs will normally work on the stomach, the gastric side. So that's why. What about raloxifene? D. That's incorrect, because raloxifene is a serum estrogen receptor modulator, SERM, and that's normally indicated for the management of osteoporosis in postmenopausal women. So it works by binding to the estrogen receptors, inhibits osteoclastic action. However, the raloxifene is typically only reserved when bisphosphonate and denosumab are not tolerated at all, which is not this particular case. Strontium. You may have strontium being used very many years in the past, okay, because it does a couple of things. Number one, it increases osteoblast activity and also reduces bone resorption by inhibiting osteoclast as well. Now, because it has side effects, terrible ones actually. It causes cardiovascular and thromboembolic events. So it should be contraindicated for a lot of patients. It's only considered really as a last resort when other therapies aren't indicated. So in which case, denosumab is safer and much more appropriate. Okay, good. Let's go through a bit more of a deeper dive into osteoporosis. one of the main things I want you to remember out of this talk today is that osteoporosis is defined as a bone mineral density T-score less than 2.5 based on the DEXA scanning, okay? And the preferred site, the area that people want for it to be diagnosed, is going to be the femoral neck. Okay. Now, you may see in trickier exam questions whereby they're saying, oh, the bone mineral density T-score in the femoral neck, in the spine, they may even use it in the arm. They may give you a range of T-scores. Now, the question is, which one do you take as the first line? Well, the preferred site really for the diagnosis of osteoporosis using DEXA scan is the femoral neck. Femoral neck. Remember that. Okay. Now, sometimes people use spine. Now, I would say the fact that DEXA scanning in the spine is sometimes not suitable because obviously there is a higher prevalence of degenerative change, so wear and tear, which can cause an artificial increase in bone mineral density, so it's not going to give an accurate reading. However, it can be used as an alternative, for example, if the patient's got bilateral hip replacement and has got metalwork everywhere, okay? And obviously you might ask, well, what happens if you've got spinal operation and you've got both hip and both spine being operated upon and got metalwork? Then where do you go next? Well, if the spine can't be used, if the hip can't be used, if the femur can't be used, then you might want to do it at the distal radius. That's the third line. So bear that in mind. Now, how do you manage osteoporosis? First line, simple, conservative lifestyle. Stop smoking, reduce alcohol intake, less than 2 units a day. Okay, that's quite important. Also, make sure your calcium intake is good, over 700 milligrams a day, ideally through dietary intake rather than supplements. But if you can't, then go through supplements. And also 800 international units of vitamin D as well. It's very important, guys, to get lots of exercise. Weight-bearing exercise is so important. So you've heard these stories, you may have read about it, even of astronauts going in space and coming back home with osteopenia on land because there's no gravity, so there's no force of impact. So that's why it's very important for elderly patients to have sometimes not just isometric exercise where they're pushing against, using body weight, but actually a lot of good weight-bearing exercise where they are being eccentrically pushed. They're doing excess weight as well. And obviously we want to prevent a fall, okay? So obviously it's best to prevent a fall and prevent a fracture rather than rescue a fracture. So if someone's a falls risk, you better refer them to a falls program as well to prevent any fragility fractures. Now, in terms of medication, in terms of management, it's really divided into 2 different categories. One is anti-resorptive and the other one is anabolic. Anabolic means the build-up, which is obviously the opposite of catabolic. You may have heard it before, okay? So the anti-resorptive treatments are the ones that you're going to be more familiar with. So things like bisphosphonate, like alendronic acid, rosindronate, zolindronate, etc. That's the ones listed here. And they work by slowing down bone turnover because they inhibit osteoclast, okay? However, there are now a new focus on the newer drugs, the newer anabolic drugs, especially in the exams, such as teriparatide and rosuzumab. Now, the first line treatment is going to be things like bisphosphonate, alendronic acid, rosindronate in the majority of cases. However, there are certain cases where you're not going to be a first line. Let me give an example. If there are side effects in terms of esophagitis, gastric ulcers, that sort of stuff, maybe you can give it intravenous, IV zolindronic acid. Very much first line, if that's the case. It's cost effective. Now, obviously, in the last case that we saw, in the last clinical vignette, the zolindronic acid wasn't offered. But if it was offered, maybe that would have been an ideal solution for this particular gentleman who needed it, if he couldn't tolerate oral bisphosphonate. Denosumab, we've discussed this before. Raloxifene, it can be used, and sometimes people use HRT, which is generally for younger women, so under the age of 60 with menopausal symptoms as well. Now, anabolic drugs, so the ones that we've listed here, teriparatide and rosuzumab, these are first-line therapy for those in a very high-risk group, okay? Very high-risk group of falls. So just, not falls, of osteoporosis. Bear that in mind.